Hello, this is Dr. Amin Marashi, retina specialist in Marashi Eye Clinic in Aleppo, Syria. I am presenting the course of OCT for macular diseases. In the previous presentation, I discussed the diabetic macular edema. In this presentation, I will discuss OCT's clinical applications in non-diabetic retinal vascular diseases, including macular edema related to retinal vein occlusion, retinal artery occlusion, macroaneurysm, and macular telangiectasia. One of the main features of macular edema related to retinal vein occlusion is the increased reflectivity of inner retinal layers due to ischemic changes. In cases of macular edema related to retinal vein occlusion, the OCT will show increased retinal thickening with empty cystic changes with or without subretinal fluids and interretinal hemorrhages, which cause a shadow artifact. Some macular edema cases related to retinal vein occlusion can be presented with vitreomacular interface abnormalities, such as a periretinal membrane that will appear as a hyperreflective band lying over the inner retinal surface, causing a corrugation. Other features that can be associated are the disorganization of inner retinal layers with or without ellipsoid zone and external limiting membrane disruption, which negatively impacts the visual prognosis. In ischemic maculopathies, there would be a thinning in inner retinal layers. This applies in diabetic macular pathy and retinopathy as well. And sometimes OCT can show the occluded vessel as a hyperreflective circle. However, OCT shouldn't replace the fluorescein angiography or OCT angiography in the diagnosis of ischemia. Some cases can present with RPE changes that may cast a shadow artifact which can hold poor visual prognosis. OCT is very handy in following up patients with macular edema related to retinal vein occlusion, as OCT is very sensitive in following up not only changes in retinal thickening but also changes in retinal structure as well. Thus, OCT can be useful to assess treatment efficacy, which is important for treatment decision making to judge if the treatment should be stopped or continued or changed. Please note that as in diabetic macular edema, the relation between the central macular thickness and visual acuity is modest. This case shows macular edema related to retinal vein branch occlusion with cystic changes and subretinal fluids with intraretinal blood that cast shadow artifact. However, the OCT cross-section shows anatomical normalization with reduced central macular thickness and resolved intraretinal cysts and blood along with subretinal fluids post-treatment. OCT has unique features in cases of retinal artery occlusion, which features increased reflectivity and thickening of inner retinal tissues, which are more appreciated in negative black and white. In contrast, old static retinal artery occlusion will feature thinning of the inner retinal layers. This is a case of branch retinal artery occlusion showing hyperreflectivity of the involved retina. In contrast, the uninvolved half appears with a normal reflectivity with adjacent to cotton wool spot which project shadow artifact. OCT can be useful to rule out paracentral acute middle maculopathy, which can be a predecessor to retinal artery occlusion and feature a marked increased reflectivity of the outer plexiform and inner nuclear layer, which usually cast a shadow. In cases of retinal artery macroaneurysm, OCT may show increased macular thickening and with cystic changes. OCT can have distinct features between exudative and hemorrhagic macroaneurysm. For exudative, there would be an increased macular thickening with empty or non-empty cystic changes and hard exudates that appear in the form of hyperreflective masses located at the outer retinal tissues that cast a shadow artifact. In contrast, hemorrhagic macroaneurysm will feature intraretinal, preretinal, and sometimes subretinal hemorrhage, which appears as hyperreflective with a smooth border that casts shadow, along with cystic changes and macular edema with increased retinal thickening, and can be associated with vitreomacular interface abnormalities such as an epiretinal membrane or Todd vitreous. OCT can be utilized to follow up macular changes in patients with arterial macroaneurysm. OCT may show macular edema improvement post-treatment or observation, which may help to follow up and treatment decision making. OCT exhibit different findings in different types of macular telangiectasia. In type 1 macular telangiectasia, there would be an increased retinal thickening with empty or non-empty cystic changes with or without subretinal fluids and loss of foveal pit. Sometimes it can be presented with hard exudates. OCT is very useful to follow up and assess treatment efficacy in cases of macular telangiectasia type 1. This case shows increased retinal thickening at baseline with cystic formation and hard exudates. Post-treatment cross-section shows an improvement of both central macular thickness and cystic formation. However, in macular telangiectasia type 2, OCT may show in early stages enlarged temporal foveal pit, but as disease progresses, it may show degenerative changes such as cavitation. However, intraretinal pigmentation will appear as hyperreflective mass, which casts a shadow artifact, and as disease progresses, the cavitation will involve inner and outer retinal layers without any increase in retinal thickening. Some cases of macular telangiectasia type 2 may get complicated with choroidal neovascularization, which exhibit increased retinal thickening and the intraretinal cystic formation and subretinal fluids, along with subretinal hyperreflective masses that may resemble subretinal choroidal neovascular membrane proliferation. Some cases can be combined with subretinal blood or exudation, and even some cases it can be complicated with a pseudo whole lamellar configuration. OCT is very important to monitor and follow up macular changes in macular telangiectasia type 2. As in this case, the baseline scan shows intraretinal cavitation, and within 5 months of follow-up there is an increase in intraretinal cavitation. Thank you for listening. I hope you find this information useful in your daily clinical practice. Please stay tuned in the next presentations where I will discuss about clinical application of OCT in age-related macular degeneration.